Thank you very much. It's an honor to be here. Thanks to Dr. Sharma and Dr. Moran for inviting me. I have the pleasure of talking about the role of newer P2Y12 inhibition, and I'm going to talk a little bit about bleeding complications as they relate to these agents in the clinical trials. These are my disclosures. I should tell you that I have one other disclosure, which is that I didn't pick this topic. I was assigned to it. And unfortunately, I do have to debate my good friend, Usman Babar. It's always difficult to debate friends. You know, Usman, I know him, I think, pretty well. He's a world-famous clinician investigator. He's helping to lead the Twilight trial. He's just an all-around nice guy. He's significantly younger than me, and he's probably achieved a lot more than I already have, so it's intimidating. But, you know, he has another side as well. He's also an early adopter of technology. Believe it or not, he has a MySpace account. Do you remember MySpace? I can't believe it. He's got a MySpace. And the other thing is that he enjoys the finer things in life. And I think that what he really wants me to do is to relax and just eat some effing tacos. But I'm not going to. I'm actually going to go through some of the data. And I'm going to try and make, in the next few minutes, 3 points, which is that while the newer P2Y12 inhibitors reduce ischemia, they increase the risk of bleeding, as does prolonged dual antiplatelet therapy. We know that bleeding is associated with increased mortality, and I will posit that this may be the reason why there is no mortality benefit in many of the randomized trials of dual antiplatelet therapy. And I think that most patients without acute coronary syndrome undergoing PCI can be treated for just 6 months with clopidogrel. So let's talk a little bit about the landscape of dual antiplatelet therapy and more potent P2Y12 inhibitors. We know that there is a balancing act. As you increase the potency of platelet inhibition, you get a reduction in ischemic events, but you get a concomitant increase in major bleeding, regardless of how that's defined in the randomized trials. So let's take a look at one of them, which is prasugrel. We know that in the Triton-TIMI-38 trial, prasugrel reduced the incidence of death or MI. Here are the bleeding events. There was an increase in fatal bleeding in this patient population, in the patients who were randomized. And in patients who had a prior stroke or TIA, that bleeding risk was largely intracranial hemorrhage. So that reduction in ischemic events was balanced by an increase in bleeding events. And if you look at the overall mortality rates, there was no significant difference between prasugrel added to aspirin and clopidogrel added to aspirin, perhaps because the mortality reduction that was achieved by a reduction in ischemic events was offset by an increase in bleeding risk leading to mortality. Now, it's a little bit of a different story in the Plato trial. Now, Plato was a significantly different trial. It randomized all comers, so you didn't have to undergo an invasive strategy in PCI like you did in Triton. These are patients who underwent bypass surgery, they had medical therapy, and in this trial, bleeding was defined as all bleeding, not just cabbage-related or non-cabbage-related bleeding. And when you look at the total major bleeding rates, there was not a significant difference between ticagrelor and clopidogrel because there was a management strategy for the cessation of these agents before bypass surgery. Now, what's interesting, as you all know, is that there was a reduction in cardiovascular death, MI, or stroke with the ticagrelor strategy, but interestingly enough, there was a reduction in cardiovascular death and total death. And perhaps that's because this is an agent, at least the way it was studied in this trial, that reduced ischemia without increasing overall bleeding complications. So I think when we're talking about antithrombotic therapy, if we can achieve a reduction in ischemia without increasing bleeding, that's really where we start seeing a reduction in mortality. Well, interesting, when ticagrelor was studied in a different patient population, that is secondary prevention, a year after a patient had had a myocardial infarction event, again, you saw a reduction in non-fatal composite endpoints. And you can see at the bottom there that for every 12 events of reduction in MACE, you saw an increase of 15 events in bleeding complications with the 90 milligram dose. And for every 13 events reduced with respect to MACE, there was an increase in 12 events with respect to major bleeding. And again, because you increase bleeding risk, there was no significant difference across the arms with respect to cardiovascular death or death alone. Again, probably because that ischemic reduction was offset by an increase in bleeding complications. Now let's talk about long-term therapy. This is the DAPT trial. You all are familiar with this. Patients who were event-free at 1 year randomized to prolonged dual antiplatelet therapy versus placebo. In this trial, a reduction in stent thrombosis, a reduction in MACE, but there was an increase in gusto severe at moderate bleeding. And what you can see here is there was a 0.5% increase in mortality with prolonged dual antiplatelet therapy that just barely met statistical significance. Certainly a concerning numerical increase in fatalities due to bleeding complications. And when you pool all the data together with these different randomized trials that have compared 6 months or 3 months versus 12 months of DAPT, you see that you do see an increased risk of major bleeding with prolonged dual antiplatelet therapy, and that increases mortality versus shorter dual antiplatelet therapy. Now, are these patients dropping dead actually from bleeding, or is it due to other potentially confounding causes? Well, Tullio Palmerini pooled 6 trials of 11,000 patients and showed that shorter duration of treatment with aspirin and clopidogrel, or dual antiplatelet therapy, was associated with fewer bleeding-related deaths. So I think I'll go back, and I think I've shown you that what the data show is that while newer P2Y12 inhibitors reduce ischemia, they certainly increase bleeding, so as does prolonged DAPT. Bleeding is associated with increased mortality, and that, to me, explains their lack of mortality benefit. Therefore, even in the current era, most patients without acute coronary syndrome undergoing PCI can be treated for 6 months with clopidogrel and aspirin. Thank you very much.